Temple. Injecting filler in this area has reported to cause blindness. The danger in injecting this area is because of the frontal branch of the superficial temporal artery that traverses the temple. This artery anastomosis with the network of supraorbital and supratrochlear arteries that lead to the ophthalmic artery. This anatomy in this area needs to be understood because there are 3 different injection planes and techniques. One has to assume the superficial branch of temporary arteries over the area of where the filler placement is. If one has to puncture the skin in this area often enough, it is probably unavoidable in hitting this artery once. Using a cannula with an entry from an area away from the temporal hollow site may avoid this problem, but it also has its limitations. First, understand the anatomy in this region. Typically over the temporal hollow, the layers are the skin with superficial fascia attached, superficial fat, deep fascia covering the temporalis muscle and then the bone. The artery runs in the superficial plane and within the superficial fascia. We can assume it is somewhat superficial just below the skin and above the superficial fat. The first technique is using the cannula. The entry is usually from inferior aspect for easier access to the area. The cannula then glides in the superficial fat plane below the level of the artery. In a way, this is similar to filler in the hands, being under the hand veins. The disadvantage about this plane is that the result can be lumpy, and if there are already visible superficial veins, this will make them even more prominent for some days. One needs to be mindful of the tip of the cannula and not allow it to migrate upwards, hitting the artery despite this being a blunt instrument. When choosing second and third technique, one must first identify the temporal fusion line and the zygomatic process of the orbital rim. The second plane of injection is just under the deep fascia. It is not possible to penetrate the fascia with a blunt cannula. This fascia is thick. When using a needle injecting perpendicularly, the first resistance is the skin. Having passed this layer, one now needs to feel the popping sensation when the needle penetrates the deep fascia. This varies in depth between individuals. Once the deep fascia is penetrated, then begin by slow injection and allowing the filler to spread just under the fascia. As always, this is a bolus injection and one may need to change the direction of the needle after injecting 0.1 ml of filler. The good points about using this technique is that one can spread the filler easily and it creates an even aesthetic outcome. The disadvantage of using this technique is the needle has to go through the plane where the artery may possibly be, and also it relies on the fill by the injector, that this has penetrated the deep fascia and the tip of the needle remains in the subfacial plane. Placing too much filler in one point may cause sensation of pressure because the filler is trapped in a tight space between the deep fascia and the bone, amongst the temporalis muscle. This may also exaggerate the appearance of superficial veins depending on the amount of fillers injected. The third injection type is 1 cm below the temporal fusion and 1 cm behind the zygomatic bone of the orbital rim. The reason for the 1 cm away has to do with the slope of the temporal bone. I'd inject within the 1 cm. There isn't much room for the filler and it will be tightly trapped between the deep fascia and the bone, causing sensation of pressure. The injection at this point is injected after the needle touches the temporal bone, so the filler is placed in the supraperiosteal plane. The temporalis muscle is tightly attached to the bone and it cannot be lifted or pulled off the bone. The filler is then spread with this plane with massage. Technically speaking, it is between the deep fascia and the bone. The advantage of this technique is that the filler is probably at the safest plane, but the disadvantage, as mentioned, the needle may go through the artery upon penetration if it is in the way. It is not easy to spread the filler depending on the distance it has to move, and more filler is required compared to the other 2 techniques to achieve the same degree of fill. In summary, it is advisable to understand and know the 3 different injection methods, but first and foremost, understanding the anatomy in the area well. Make sure you visit our website and sign up to our exciting and informative injectable and skin courses, and more.